Welcome everyone to today's webinar on staff care with Dr. Deb Marin from Mount Sinai, New York, a wonderful colleague of Transforming Chaplaincy of the Chaplaincy Innovation Lab. Very happy to be here with her today. I just want to take a moment here at the top to thank Transforming Chaplaincy for partnering with us on this, and also the Henry Luce Foundation. This is the second webinar in a series on staff resilience, supported by the Luce Foundation, and so we're grateful to them for supporting this important work. I do want to mention just briefly here at the beginning the next webinar coming up from Transforming Chaplaincy, which is on November 19th at noon Central, 1 o'clock Eastern. This one is titled, "Okay, so he has some religious beliefs, spiritual care and palliative care research," with Dr. Natalie Ernikoff and Dr. Joe Rotella. You can find more information on that event at transformingchaplaincy.org. With that, I will get out of the way and turn it over to George Fichette.
Hey, Michael, thanks so much. Hi, friends. George Fichette here, Professor of Religion and Health at Rush and Director of Transforming Chaplaincy. It's my pleasure to welcome you to this webinar on supporting staff well-being in the COVID-19 era, a conversation with Deborah Marin. I want to say that this is the first webinar that is co-sponsored by Transforming Chaplaincy's new network for spiritual care managers. The network grew out of our certificate for spiritual care management and leadership, and we want you to kind of keep your eyes on the Transforming Chaplaincy newsletter and website for information about the 2021-2022 class for the certificate for spiritual care management and leadership. Our featured guest today is Dr. Deborah Marin. Dr. Marin is the Blumenthal Professor of Psychiatry at the Icahn School of Medicine in Mount Sinai, New York City. She's the director of Mount Sinai's new Center for Stress, Resilience, and Personal Growth. Many chaplains will know Deb's name as the lead author of the Journal of Healthcare Chaplaincy's second most downloaded article, the 2015 paper, Relationship Between Chaplain Visits and Patient Satisfaction. Under Deb's leadership, Mount Sinai's Center for Spirituality and Health has been a leader in evidence-based spiritual care. Leading today's webinar is Ben Schaefer. Ben is a board-certified chaplain and manager of spiritual care for Ascension, Michigan. That means he's managing the spiritual care programs in all of Michigan except for Detroit, if I remember correctly, Ben. Ben is also the convener for Transforming Chaplaincy's new network for spiritual care managers. And joining Ben in the conversation with Dr. Marin is my colleague, Dr. Andrew Garman. Andy is a professor of health systems management at Rush University and program advisor for the National Center for Healthcare Leadership. And Andy also co-directs with me the Transforming Chaplaincy Certificate in Spiritual Care Management and Leadership. We're really delighted to have you, Deb, and Ben and Andy. And I'm going to turn it over to you now, Ben. Thanks so much. We're looking forward to the webinar today.
Great. Thank you, everyone, for being with us today. This is an honor for us to have this conversation. We're going to spend the first part listening to Dr. Marin kind of present what's been going on at Mount Sinai and this amazing work. And then Andy's going to give a little bit of a summary of how this award and process went together and how that's been working. And then we'll spend the rest of the time in kind of conversation, question and answer. So I invite you to be thinking of questions and be bringing them forward as we go through that. And with that, I'll pass it on to Dr. Marin.
Thank you, everybody. Andy, George, you're just amazing folks. And thank you for inviting me. I've given this talk in many different venues, and I have a spin to this because we recently had what we call administrative grand rounds once a year for our department. And my colleague, Von Sharma, who's involved with the center as well, Health, put together some data that are quite compelling, what the chaplains did actually for staff during this extremely difficult time. So stress is an interesting thing. You know, some stress is actually good. It sometimes makes us work harder. We are trained to actually be aware of our environment, to run away from animals and things. So our brains are actually kind of accustomed to having some kind of stress. The problem is when the stress becomes overwhelming and people can develop different conditions. So I don't have to go into the diagnostic criteria. If you think that's necessary, let me know. But the symptoms that people have when they're under stress, could be major depressive disorder, they're person not interested in doing things, they're depressed, they sleep too much or too little, they can't focus, they may have thoughts of death and dying. It's a sixth leading cause of death actually in the globe. The other one is acute and post-traumatic stress, meaning acute is when you're in the middle of something and you're stressed out, but post-traumatic stress disorder by definition is it happens after the stress. What makes this so difficult is that this is not over. It's an ongoing threat. So we may have acute and chronic conditions going on. Then, of course, there's anxiety disorders, and there are many reasons why people have a lot of anxiety these days, as you well know, what's going on in the world, our environment. And when people are anxious, they worry. But when you have anxiety disorder, it's overwhelming. It takes you over. You lose sleep. You can't focus. And alcohol use disorder, you may be aware of the fact that alcohol use disorder has anyway been on the rise in the past decade. Alcohol sales in America has gone up 12% during the period of this pandemic. And that's what somebody drinks when it causes problems for them, causes problems at work and their relationships, and person kind of wants to make sure they always have some alcohol around. That's alcohol use disorder, let alone about the opiate issues. I do want to talk about moral injury. I know chaplains have been involved in this research, and moral injury is, it can be viewed as post-traumatic stress disorder, but there's some differences. The difference here is that PTSD is considered to result from a person being a victim of something that happens to them, right? They were exposed to something. Here, it's difficult in functioning and sometimes following exposure to potentially more injurious events. And they relate to one's own actions or inactions. And as you well know, during the pandemic, people didn't know, should folk patients be on their belly or on their back? Put them on a ventilator, give them hydroxychloroquine, how infectious is it? People were deployed and redeployed to places they weren't familiar with. They had new assignments. So there are many things that people were placed into positions that made it very difficult, and they may now think they didn't do the right thing. And then this has a lot to do with the fact, was there enough PPE? Were there enough ventilators? Did you decide to not let somebody live because our hospitals were completely COVID hospitals with thousands of beds, all full of COVID patients? Did you not screen the person correctly? Did somebody then get exposed to COVID-19? Are your visitor policies good enough? Do you agree with them? Do you think they're correct? Then the rationing resources I mentioned, we were very lucky in New York. We had airlifts from China for PPE, not so lucky in other places. So often the person kind of suppresses or avoids this, but I think it's a very relevant issue in the world of chaplaincy in terms of what you may be hearing from patients. That's one thing. So here is a busy slide, but I wanted to kind of orient you. This is the event. Let's say a tsunami. Then what happens to a person a year later and 2 years later? And this has to do with how much you're affected. Not affected very much, you're affected a little bit, somewhat, and very severely. And these are the courses that have been found for many disasters around the world, no matter what they are. If you're really destabilized by it, you're likely to continue to not do well. Symptoms persist, it's called chronic. Then there are people who, let's say healthcare workers, where they got a moderate dose, they didn't feel good, and they go two different ways. They can get better over time, or they can go and get worse. And then there are the folks who are resilient. They just were not phased, and they just have resilience. Who is more likely to have these symptoms? It has a lot to do with where you were, who you are, and what you did. If you were in the middle of being a healthcare worker, surrounded by, we had people die in the first 4 months of our hospitals, the number of deaths would have been in the complete year, right? How much were you in the trenches of it? How were you affected economically as well, right? Did you have prior exposure to trauma? In some ways, trauma can make us stronger, but sometimes previous exposure, unless you've really recovered, makes us more vulnerable to again be traumatized. Having a past psychiatric history, if you have problems before the disaster, lack of social support, tremendously important in terms of being supported by somebody. People often don't ask for help. And other things going on in this world, fear of violence, fear of being hurt, being profiled, all the things we know are existing, being female, and not being liked. And a lot of people say this has a lot to do with the fact that they had a lot of exposure to trauma anyway, in a chronic level. So where are we now? This is a slide from SAMHSA, and so, you know, lugging along before the disaster, impact happens, and you know, and a lot of healthcare workers don't like to be called this, they were considered heroic. They just worked 12-hour shifts, they didn't take time off, they didn't see their family, and then disillusionment. And we are squarely in the disillusionment phase. People are tired. They don't want to reach out. Sometimes I do other work regarding conflict. I sometimes call this presenteeism. You checked in, but you really checked out. And now with the different waves coming across, the problem is you have a trigger event, more people coming in, you're worried about the percent of COVID infection in your community, you're not going to do so well. But the goal is, of course, here, the goal is to reconstruct, and that's what I'm going to talk about. This is Mount Sinai. It's a view from our, actually it's a view of our campus. This is our research building. I work in this building. This is Central Park. I actually live over here. And what I'm showing you here is data that were collected on our healthcare workers during the pandemic, and it's exactly the same no matter what study you look at, be it healthcare workers or be it just done with the epidemiology in the States right now. So we have an Office of Wellbeing and Resilience, and they pulled together a survey, and 6,000 healthcare workers were invited to do it. 3,060 completed it. Not a bad response rate for a survey, almost 56%. And only those individuals who have complete data were used. So what did they look at? They looked at the incidence of major depression, generalized anxiety disorder, and acute or post-traumatic stress disorder. And very sadly, 39% screened positive for at least one. And a lot of grieving, a lot of major depression, and a lot of anxiety. We expect this, we don't know where this is going to go. They just did another survey, it's actually a week ago. My assumption is it's going to look a lot like this. Now, chaplains. So Andy and George know very well that I like data. And we have what's called a REDCap database. It's a confidential database where our chaplains enter information into regarding staff supports, since all of you chaplains know you do a lot of it. This is a conglomeration from October 2019 to just this past month of how much chaplain supports are done in this is a conglomeration of 6 hospitals. So you can see, you know, chaplains are a lot of support, you know, 444 events, you know, October, 369, but kind of similar ballpark per month, a lot, right, in any 30-day period. But then look what happened. 860 events in total, thousands of people were using us all, sometimes at the same time. And now we're down here again. And I do think it has to do with disillusionment. We have a database of all the folks that were helping out. We had Employee Assistance Program, we had Employee Health Service, we had Department of Psychiatry, in which I am a member. Chaplains by far were the most used. My opinion, it's because they're trusted and they were out there, and chaplains take care of patients and the team. So this is past year. It is true that 51,000 folks, that could, of course, be repeats, were taken care of. But this is most often, right? The chaplains do a lot of debriefings. Nurses rely on us, on them, it's not me. Followed by folks, particularly in the pandemic, respiratory therapists, a big one, environmental services. These folks, you know, we had trucks outside for those who passed away, right? Physicians did use us, not so much, right? But the point here is that we were heavily used, the departments were heavily used. And why? Workplace stressors. And these bumped up a lot during the pandemic, world community crises, personal stressors. And what do the chaplains do? A lot of one-on-one conversations, a lot of debriefings, prayer blessing, but you can see the difference. This was not the major thing, because we know chaplains do a lot of emotional support. and staff support. So now going on to resilience. Resilience is not an on-off switch. You're not born resilient or not resilient. There may be some genetics to resilience, that may be true. There's certainly environmental aspects to resilience, but it's really a process in the face of adversity or trauma. People actually need to have some stressors to become more resilient. That's something that's been shown a lot in the literature, that when folks have not had any adversity, maybe the few many white privileged people can think about, you know, but the bottom line is that this is something that can be enriched. And there have been research to prove that it can be. It's active in a dynamic adaptation. Nobody is or not or is. People are more or less, and it can change over time. So now about the center, since you guys want to talk about our center. The Center for Stressful Interpersonal Growth actually started, there were so many issues for workplace environmental issues. The workers were so stressed that a lot of initiatives were going on in the middle of March. And basically, by the first week of April, we realized that this is not going away. We have to do something for our folks. So I was asked to run it on April 27th at 9:30 in the morning. And it's been a very fast ride. I view us as a startup to some degree. We know the pictures has been changing, and it's getting worse, as I think you will know, in Manhattan again, actually most part in actually Queens and Brooklyn. So the idea here is enhancing the mental health following the COVID pandemic, during the COVID pandemic, and it is available for all 42,500 folks in the health system. We opened our doors June 22nd. We started our training program July 22nd. We realized that the Department of Psychiatry, great Department of Psychiatry, that their clinics were getting overwhelmed. They were already 90% capacity across the health system. So our CEO and our dean said, we want to take care of all of our workers with no copay and no deductible. And we've been working with a lot of folks to make that happen. So we opened up our treatment doors actually 2 weeks ago. Okay. The first thing we did, kind of followed what a lot of work has been done with veterans, is develop an app. If you want to look at a free app, it's really that we are a version of. It's called the COVID-19 app. It was built by the Department of Veterans Affairs. It's free. We wanted to build an app that is for our workers. That's highly confidential. This app was approved by Google and by Apple, but it is not in the App Store. You can't see it. And the purpose of the app is in real time to find out, first, you can journal how you're doing with a journal function, assessing one's mood with depression screen, stress reactions, including, post-traumatic stress, but also resilience and well-being. By the way, we have spiritual resources. Thank you, George Fischette. We have your 2 questions for spiritual struggle here, which is unusual for an app to have in a medical setting. And the idea is that somebody can actually click in how they're doing, and immediately they get feedback. This is an older version. We're in version 2 right now. Just got released actually for Android. And it's in English and Spanish. And the idea here is based on how people fill in the form, they get either green or they get yellow. And now we've adapted it that actually people get different answers when they do it over each day. People get actually an opportunity to see how they're doing over time. And the app now, based upon what I'll say in a second, we initially started with the first iteration of resilience workshops. This is based upon a book by Dennis Charney, my dean, and Steve Southwick, amazing researcher. And we said, we're gonna have resilience workshops. We got to have them. We're going to be available. Our doors are open 7 a.m. to 9 p.m. 7 days a week. The social worker is always available, actually, for the phone call. And we thought this was going to go great. And we got great idea. Let's do resilience workshops to promote health. These are the embracing optimism, facing fears, social support, moral compass, living by values, meaning and purpose. They're all very, very related to what chaplains do. All the chaplains were trained to be leaders in this, and then they didn't come. We even got HR to give anybody permission to not take time off. They can do it after lunch break, and nobody came after the first week. They were tired. They had trouble congregating. It was all virtual. It was just too much, too long. So we decided to change them to 5 workshops, and we're also going online and using digital health as a platform. The app will be a methodology for people to listen to 2 to 5 minute tapes done by resilience experts on the different issues I just talked about, collapse into 5, so people can actually go with their cell phone when they're on a break, watch it, and then they can join groups of folks to do the workshops, 20 minutes each. We just are launching that as we speak. We know that we had over 70 workshop leaders trained. Chaplains are constituted by 25 of these, and people loved it anonymously. They really felt it helped them manage themselves. These are now the 5 workshops: optimism, active coping facing fear, social support role models, and David Fleener did this one, for those who know David. Again, nothing's available for outside of Mount Sinai because the app is all inward focusing, but we're probably going to post this so people can look at it as well, just to learn about some of the stuff. We've learned that we have to use a blended learning to enhance resilience. So we were hoping we'd have synchronized learning. And for folks who know, a lot of people do unsynchronized learning. Example is you can look at the app for 3 minutes, right? You learn what you want, and then you can do a workshop in a synchronized way. The use of videos, picture is worth 1,000 words. Photo voice is a methodology that you can take a picture of your environment, load it up, and share it with others in your group so that people can feel how others are feeling and see. We're training people through the app now, and we're promoting group activities. This is a very fast-moving thing I'm talking to you about. I'm not the one who put the heavy lifting into this. I have to tell you, John DiPiero, who's the clinical director, is an amazing young man who runs all the day-to-day operations. Those of you know Ron Sharma, he's responsible for performance improvement. And we've had a lot of people help us out with this. Fortunately, we got seed money. So now we're doing clinical care. We've hired 4 social workers. We have a psychologist and a half-time psychiatrist. And the best treatments for a lot of stuff I'm talking about is not medication. It's actually cognitive behavioral treatment, interpersonal therapy, clinical behavioral therapy, and there, of course, is a backup for pharmacotherapy. And for those employees who are eligible for clinical care, meaning they are functioning still, they're not suicidal, they don't have a primary substance abuse, any employee can download the app. We have something called Sinai Central. Everybody has a place where they have to log in. You can download the app. Nobody knows what you're filling it in, just that you downloaded it. And we're really promoting the fact that this is highly confidential to the point where we found spaces around the health system in non-psychiatric areas. We're calling them pods. We're working with digital health folks and there's some really interesting folks in music and senses to create what we're calling pods, these immersive experiences where employees can go in very privately and be seen remotely. And we hope at one point they'll be seen in person. So that is my talk. Thank you very much.
Thank you so much, Dr. Marin. That is wonderful. Andy, would you like to do your part?
Sure, I'm happy to. So let me also thank the team here for the invitation to join. Honestly, just wanted to hear what Deb had to say in a part 2 fashion. I had interviewed Deb as a part of some outreach that I was doing with this nonprofit organization that George Fichette mentioned. So to put this in a little bit of context, the National Center is a nonprofit organization that's been around since 2001. And one of the important areas that NCHL works on is evidence-based leadership practices. So we're a little bit doing what Transforming Chaplaincy is doing for spiritual care and chaplaincy professionals. We try to do the same thing for healthcare executives who don't always follow evidence-based practices themselves. One of the signature programs that we run is called the Best Organizations for Leadership Development. It's a survey that we field every other year. It's free to participate in, and it's built around best available evidence in terms of what works in leadership development. We've been wanting for a while to include a dimension on this survey on well-being, but the data really wasn't there to support putting something together. That's been evolving in recent years, especially, and this was starting to really come together even before COVID-19 showed up. And a couple of quick points I want to make about what the data are suggesting. Number one, there are some individual skills that are very important to develop and to master. And Deb spoke a little bit to the experience of working through hardship as a path to increasing resilience. There are other skills in terms of things like transcendental meditation and many of the other skills that are in the toolkits of a lot of folks, I think, who are on the call right now. But that is only part of the equation. And another big important part is the environment of care and how the environment is structured to support and help clinicians and other staff feel supported. This is an area where, as Deb mentioned, and I'm sure this is the lived experience of many on the call, we were put to the test in a big way in most of the healthcare providing organizations across the country over recent months. And there's some work coming out of a couple of scholars, one in particular, Tate Shanafelt, who's the chief wellness officer at Stanford and previously was with the Mayo Clinic, which was starting to put together a characterization of what's the organization's responsibility or what's the organization's side of the equation in terms of supporting staff and clinician well-being. So the survey that we put together and fielded out to the health systems this time around, it included some elements in terms of what sorts of programs are being provided that people can avail themselves of, but it also had a heavy focus on what structurally was the organization doing to preserve well-being and to support well-being amongst its staff. And so to give you just a little bit of a view into some of the types of questions that go into that, number one, is there somebody with a title like Chief Wellbeing Officer in the organization? In other words, a visible representation that this is important to the organization. If that person exists, are they a part of the senior leadership team, and are they in a position to influence critical decisions that are being made that will impact staff? In addition to this, if you look at things like how the quality of jobs are measured, right now there's not a standard sort of a set of quality indicators for people's experience in the job, but there are a lot of ways that one can start to get at these types of questions. And so part of the work I think that we're going to see in the coming years is developing some sense of standardization of what does that look like. So to give you a couple of examples, before COVID came onto the scene, there was a lot of concern that was starting to be risen from physicians especially, but really anyone who has to regularly interface with the electronic medical record. When changes would happen that would change the requirements from a documentation perspective, it was often very difficult proactively to understand and appreciate what sort of an impact this was going to have on clinicians. And so what some organizations have started to do is take measures of things that they call, there's one term, pajama time, which is kind of a colloquial. I think a more precise term is work outside of work, but it's how much time a person is spending after they return home in the electronic medical record to complete documentation steps. There are other measures in terms of subjective well-being and the experience people are having in the workplace. But the final piece I want to mention here, if we take a step back and we think about health systems in terms of the mission that they profess out to the world, which typically has something to do with improving or maintaining health, the quality of work, the type of work that people do, the security they have in their jobs, these are all known social determinants of health. Number one. Number two, health systems as a workplace in most counties in this country are the largest employers. They're also one of the biggest chunks of the gross domestic product. There is a compelling, I believe, rationale for health systems to not only worry about and think about, well, how do we get people back onto the road of recovery? How do we build their resilience? But even taking a step further and thinking about, how do we turn the workplace into a source of health? How do we set up jobs so that they're health affirming? I really think that's the high bar. And I've seen some health systems really start to look past the post-traumatic resilience and start to look at post-traumatic growth and how do we take ourselves and our colleagues to this next level. So my final quick comment, I did reach out to Deb, as I mentioned before. Mount Sinai is one of the organizations that's going to be recognized as the best organization for leadership development, particularly for the work that they're doing in well-being and resilience. They'll be recognized here in a few weeks. We have an NCHL annual conference. If anybody's interested in taking a look at what's on that program, you can see it at www.nchl.org. Thank you again for the invitation, and thank you, Deb, as always, for sharing your wisdom and your experiences.
As with you, Andy, always. I do agree that everything you're saying, Andy, is true. People are, particularly health workers, are very tired, so the institution has to do that. No question.
Thank you both for sharing. This is a wonderful conversation. For those of you who are on the call, if you have questions or comments, I invite you to use our chat feature here as we're waiting for some of those to come in. One question I had for you, Dr. Marin, was you talked about all the data you've been collecting on number of interventions that chaplains and social workers and psychologists have been doing with care of staff. How have you been tracking that? Because there's historically hasn't been a good, precise way to do that since you can't track it in a medical record necessarily.
So there's something called REDCap database. It's an open source database. It was developed by Vanderbilt, actually, many, many years ago. And it's very easy to use. It's, as I said, it's open source. Maybe your institutions may have it. And you can build, it's not that hard to build, actually, a database that has what you ever want in it. So our databases, for example, have, who was the chaplain, where they work, where they do the intervention, what floor, how many people do they work with, and what kind of intervention did they do. That's where, I think about George Frechette when I say this, that's where some inter-reliability issues, like one chaplain they call it work stressors, some they call it life stressors, but we keep it, and you can enter data on your phone. It's a very useful database, REDCap. I strongly recommend it for folks to look at it.
Thank you, Dr. Marin. I'm just looking here to see if we have questions. Someone was asking, would you be willing to share your slides from this with us?
Sure. I mean, the slides on the data from Mount Sinai, I can't share until it's published. Okay, that's one thing I can tell you. It's not appropriate for me to do that, but it will be coming out. I know it's in review and don't know when it's going to come out, but that's the one thing I cannot do.
Mm-hmm. All right. So here's another question. At Mount Sinai, what kind of support is available for the chaplains? Who's providing spiritual support and emotional support to the chaplains?
This is a big concern of mine. The chaplains were trained in the workshops, and by the way, we didn't talk about how confidential things are. So our social workers do confidential screening in a REDCap database. It's not a part of the EHR. And so the chaplains have the ability to find out how they're doing. I know they've taken advantage of this. I don't know who, but I think some of them told me. And they can get free care, just like I was talking about it, no charge to them. So my concern as a leader is always asking, how's everybody doing? There's some things that chaplains didn't want to do anymore. For example, this thing called cheat time. You may be aware of it. It's kind of like, not really called lavender, it's not just emergencies, but it's a very beloved activity. I didn't even show you that data. People love it. We published on it. But I've stopped. Some chaplains said, I just can't do this. I said, skip it. Don't do it. Let the folks know you're afraid. You don't want people to take off their masks. So, the other thing that I'm doing is that if a chaplain can work remotely for part of the week, they can work remotely. It's fine. That's the best I can do right now. But hopefully it's good enough. I get the barometers. I know how folks are doing in general. They're stressed.
Another question was asking, what was the financial investment in developing and maintaining this app?
Can't give you the exact number, but it's a lot. A lot of money. You can think
Yeah.
definitely 5, if not 6 figures. This app is very sophisticated. The initial spend was not very much. You can build a very simple app. That can cost not that much money. But this is a very sophisticated app, and we got seed money. We also got a lot of philanthropy from outside people. Very lucky. Very
Was
lucky.
it developed in-house then for you, or was that done by someone else?
We have a lot of researchers. It's called the Hasel Platinum Institute for Digital Health. These are folks who are amazing. They do research in digital health. They've created spin-off companies already. So we had tremendous in-house expertise, and also they had been working on something else called the Warrior Watch. It's a study that looks at heart rate variability through the Apple Watch, and they built the code for that app. So we already had a foundation.
Next question is for you, Andy. Can you repeat the web link for that conference?
Oh, sure. Happy to. Thank you. It's www and then NCHL, which is the acronym for National Center for Healthcare Leadership. So www.nchl.org. And if you just go to the main page, you should see a whole bunch of stuff on it about the conference coming up. It's the big deal for the year. So that's why I'm not sending you to a sub page, but definitely worth taking a look at. And thank you for the question.
I was looking at it earlier, and it's a big thing right front and center as soon as you open the page.
The quick thing I might just add to that in terms of the work of NCHL is we do try to help senior leadership bring together all of the kind of concern, whatever is bothering them, keeping them up at night. How does that come together as a coherent whole? And this has been a year when there's a lot on senior leadership's minds, just like the rest of us. It's not just well-being, it's not just the pandemic, it's not just social justice, but it's when you pull all of these together, how do we make this work as a coherent whole, and what are the right things to really take on first?
Yeah. So another question, getting back to that whole financial thing of spending so much on an app, which is great that you're able to get the seed money. Many organizations right now are so focused on the finances being the bottom line with COVID and with being in an era of cost reduction. How do you see this as something that's really beneficial that you can convince leadership of should be a financial investment to be caring for their staff and their associates?
You mean to build an app?
Not necessarily, but the whole program, the whole
program. You know, the truth of the matter is, aside from the app, these programs are not very expensive. They're cost centers. You know, what I mean is that, you know, you need a place where you have a computer for virtual care. I mean, I was very concerned about, so for me, the investment would be finding private places for people who don't have computers that people can go and log in for virtual care. That would be the kind of investment. So excluding the app, you know, it costs money. I think is extremely important. It really depends on the financial solvency and leadership. I got to tell you, our CEO and our dean, like, they were just on it, you know. So I think it's critically important. To me, Andy's view is a much larger view that I think is really relevant, which is what is your return on investment, quite frankly, for making sure that your workers are functioning. It's a patient safety issue, right? Forget about other reasons. If people are depressed, right, or they're overly anxious, when people are depressed, they don't think straight. When people are overly anxious, a part of their brain that takes emotion and experience gets overwhelmed and they can't function, right? So you don't need a lot of high tech for this. You really don't, but you do need manpower.
If I could build on what Deb started, I think one of the tricky things here is, you have a CEO who's paying attention, and they can quickly say, this is pennies on the dollar for the kinds of hardships that this well-being is helping prevent. For the more skeptical senior leader, there actually have been some decent attempts. Tate Shanafelt, I mentioned before, I'm happy to send his reference. He's put together a financial analysis of what are the sources of cost savings that are associated with taking well-being more seriously. The tricky thing from a science perspective is how do you parse this out in a way that is efficient and then it draws back to the well-being. But the cost savings themselves are actually not that hard to point out. Anytime you have a situation of, I hate to start with this one, but a physician suicide or a resident suicide, these are very significant costs, not just in terms of any sort of a direct impact, but the impact on people's ability to function effectively. You can measure the amount of time off they need to take. You can measure things like patient safety, as Deb mentioned. Turnover is a huge cost. If you have somebody who leaves the profession because they feel like they just can't cope with it anymore, very significant costs associated there. And in the human resources department, analyses of replacement of physicians or nurses or other care providers who are in short supply, these quickly add up. And any sort of ability that an organization has to better manage that, even that level of impact on staff. Again, it's just sort of, you find one of these savings and it becomes very apparent that these programs pay for themselves.
Yep.
So someone else asked here, what would you do then with a CEO who says, we have EAP for that, we don't need to do something in-house? How do you see this as being, in addition, a more significant benefit than referring to an outside EAP program?
Yeah, I'm going to jump on that unless Deb would like to first.
No, please, go for it.
I'm gonna fall back on a colloquialism, which is an ounce of prevention being worth a pound of cure. I'll start with that. But I actually think it's a decent question in the sense that one of the struggles that I'm seeing in a lot of health systems is they see a lot of activity happening that is all ostensibly about supporting staff. But what they don't have is a coherent whole in terms of how these pieces fit together. And you might have EAP running and taking care of individuals who self-identify, they're comfortable coming forward in a self-disclosing way. Against what like Deb was mentioning, she's found these terrific workarounds where if a person's not comfortable disclosing who they are, they can still be serviced. That in and of itself, I think, is an argument for, okay, well, if that's the case, if people are availing themselves of this service, clearly this is a barrier to people accessing EAP or other resources that we say, well, it's out there and they can have it. Similarly, there's a fair amount of research to suggest that the people who avail themselves of well-being resources that are voluntary in nature tend to be the people who need them the least. And so there is an access issue for a variety of reasons. It could be psychological in terms of somebody deciding they need to be self-sufficient, or there could be other perceptual concerns that people have. Culturally, they feel like they don't have the permission. Yes, this is something that's out there, but it's not for me. I'm not the one that they're targeting for this. And we're just starting to get our arms around how complex this challenge is. So really, that's sort of, what I would say is hopefully in the coming months, I'll also have more data to provide in terms of leading organizations and the adoption of a chief well-being officer and the adoption of these systematic and strategically aligned programs that will also help make the case. One of the things that I've found can really sway a skeptical CEO is if the CEOs of places like Mount Sinai are doing this kind of work, it can start to get other CEOs to pay attention.
We have a lot of questions around the app. There's a lot of excitement about that idea, which is cool to see. One of the questions here, someone's asking, do you see this app being used after COVID, post-COVID? Is there a place and a role to continue using this? Can you see a way that you would have liked to have had it even pre-COVID using? So Deb, I think
Absolutely. I mean, you know.
Oh, there we are. We can hear you.
Oh, I'm muted? Oh, okay, okay. The app is, so that's why I said, look at the COVID-19 app, the COVID Coach, that's what it's called, okay, that the VA built. It's free, all right? Because there's so many issues with PTSD in soldiers, right? So I think this app is a great way for people to very confidentially see how they're doing. They get immediate feedback. And I didn't even talk about the fact that the app links people to other resources at Mount Sinai, including the AP, including like Mount Sinai Calm. We've got yoga, we've got music. We have the Louis Armstrong Music Institute working with us. So I think a simple baseline app would be check in. You can check in, you know how you're doing, and then you can quickly click on a link or make a phone call that you can at least speak with somebody confidentially and find out what resources there are. We have tons of resources at Mount Sinai, and they're siloed. Not so much anymore. You know, I have to tell you, this center with the Office of Wellbeing and Resilience, we really, and that's run by, actually John Ripp, who's very well known in the wellbeing sphere. He's nationally renowned. His job as an internist is actually to work with us to destigmatize mental health. But getting back to the app, I like the concept of the app because you don't have to call anybody to find out how you're doing. You don't have to, you know, you could check on yourself. That's why I like it a lot. I think it's a great opportunity for digital health too. When, you know, most hospitals can't do this. You know, I know that, but digital health is here. There are companies that do it. One called is Clicks. It's very interesting. It actually was developed by a previous person who worked at Sinai. Brian Acavello, a brilliant young man, and he uses the app to help people do smoking cessation. So we're not in a space that is old, but it's not very new either. So I think digital methodology, again, I'm not an expert, but from what I'm seeing, it's there. Long-winded answer.
Thank you. A couple people are asking about the spelling of REDCap. It's REDCAP.
Yes, CAP. Just REDCap database. Just Google it. You'll find it.
Yeah. So a couple chaplains here are asking around what recommendations have you seen from the data you've had so far of proactive approaches as we're seeing second waves, third waves coming here, just to be proactive and prepare to continue to support the staff as they're going into these harder and harder situations with less and less energy?
So one thing I didn't talk about was there was a legion of activity from Office of Wellbeing and Resilience and psychiatry. 80 folks from the different departments of psychiatry actually became mental health liaisons. They walked around the floors. One big thing that helped a lot, and it doesn't have to go a lot of money, is they identified these rooms that were not used space for staff to go. Now, again, we were lucky. David Petrinos is brilliant physical therapist, neuroscientist. And he used a bunch of opportunities with music and sound, and not even necessarily food, but for people to go to they're called the recharge rooms. So I do think identifying a space if possible where the workers can go to decompress, particularly there's so many workers who don't have offices, I would say that's a really smart idea. I think the other thing is leadership should do as best as they can to destigmatize mental health. This month is Mental Health Month. We're working with the Office of Wellbeing and Resilience to help destigmatize. We're getting the word out. You know, that's the best thing I would say. You know, we're doing a lot of other things, but I think basic needs. I think employees need to see that at the very least, their basic needs are being met on their work.
Another person's asking about in the app, you had mentioned that there's a section of spiritual resources. Could you speak a little to what someone might find under the section of spiritual resources?
In terms of what we do, or in terms of what we know how spirituality is important?
I think they were referring to in the app, there's a tab of spiritual resources. What might they find in there?
So we are using Stephen King's and George Petrett's screening question about spiritual struggle. And if they score anything on any of the questions regarding struggle, they immediately get pulled up the phone numbers of our different chaplaincies to call. So that's how that's working, so that they can, reach out. And chaplains are beloved in health systems. They actually are pretty amazing. So that's where that comes in. And there's also meditation. There's a link to meditation in the app. And his point about TM, we're thinking of including that as well.
As you know, there have been always a history of kind of the struggle between social workers and spiritual care and psychiatry, and what's psychosocial, what's spiritual, what's emotional, and how those all work together. How have those different teams been working together in this project?
Like I said, I'm a very lucky person. Okay. Our head of social work, Susan Bernstein, for the system, actually just unfortunately decided not to take early retirement at this point. I've had a very good relationship with social work leadership over the years. So then, and quite frankly, the chaplains who work in the center are really good at working with social workers. There has been very, very, honestly, not much competition at all in our health system. Psychiatry, if you know other parts of psychiatry, they're different in their nature. I am a psychiatrist, so lucky again that they trust me even though I'm a shrink. So, it's worked out well. We're very lucky. That has not been an issue.
Yeah, if I might add a comment, there's been a decided split, I would say, and is what I've seen in health systems response to COVID-19 around well-being, and the organizations that had good relations going into the COVID-19 pandemic. When I say good relations, I mean EAP was talking already to social work, was talking to, we mentioned a number of resources. The other ones I would add, Diane Adams at Mount Sinai, very well thought of chief learning officer and the learning function in terms of bringing managers in, helping them understand the support roles that they can and should be playing on behalf of their teams, another important resource to bring to the table. Where those relationships existed, they tended to strengthen, and I saw some really fantastic work come together. In the places where those people didn't know each other, often the stress of the COVID-19 actually, I think, created more difficulties in terms of turf battles, in terms of trying to grapple with what our responsibility and role should be. This was a time that was tough for everybody, and lots of people's roles were evolving, but the ones that were successful, they already had a base that they were working with typically. My hope in some of the work that NCHL is doing is that we can start to describe some of these models in terms of advantages and trade-offs going forward, because I do think it is important for the types of, this sort of ecosystem of health and well-being that Deb is describing at Mount Sinai becomes more the model for other health systems.
Yeah, Andy, you're spot on. Task force was developed like the third week in March, 1 week after this whole thing started, and everybody knew each other and trusted each other already. So we're on it. That helped so much.
Hey Ben, this is George Fitchett. Can I jump in and just bring your attention to a question that got asked about 15 minutes ago by Trish Matthews? And maybe this is a place kind of for Deb and Andy to kind of wrap things up. Trish was asking, what's the specific thing that can be done to support staff well-being and resilience? I'm being asked as a chaplain by our chief nursing officer and HR department to meet with staff to listen. And I'm not sure if that's going to be meaningful. What's your thought? To what extent is staff being able to stop in the hall, listen to people for 10 or 15 minutes, maybe sit down with somebody over a cup of coffee? I guess you can't do that right now with social distancing. But, in the midst of some of the profound stress that are associated with being a healthcare professional working in the COVID environments, is just listening to somebody going to be good enough or important enough? You guys, any comments about that?
I think it's necessary, but not sufficient.
Yeah, I would agree with Deb, although I would augment to say listening is very important in its own right, and there are people who will seek out a spiritual care provider. There are others who will seek out a social worker, others who will seek out a close friend or colleague. But the more that we can provide those sources of social support, I think those are important and valuable. The piece that I would add in terms of being asked to listen is to the extent that a feedback channel is created. I've been a big proponent. I think spiritual care providers are in a unique position to understand the hardships in a dimension that others just are not going to see, not even HR and learning and organization development professionals. It's a different window into some of the opportunities and some of the difficulties. If that can be built into the feedback channel and productively used in terms of organizational growth and development, I think that could be hugely beneficial.
That's very, very correct.
So Deb, when you say it's not sufficient, that points to the listening chaplain being ready to follow up with something. Is that what you're thinking?
What I'm thinking about is that being present is what chaplains do. They do such a good job at it. And that there has to be more than that to get if 40% of people are having a psychiatric condition, right? Listening is fine, but it's not going to treat the problem, right? That's not what chaplains give. Emotional support. It's phenomenal. A good leader gives emotional support. But the thing is, there has to then be the opportunity for people to actually get care easily. That's what I'm talking about. For those 60% who do not have problems psychiatrically being listened to, and finding the low-hanging fruit, like I mentioned, even a safe space just to sit is private. That kind of stuff goes a long way, sure.
So chaplains, in some sense, need to be able to be aware of that 40% who need additional help if they're not already getting it, and being able to help those people say, it sounds like this has really been getting to you for a while, and I wonder whether or not you should be using, the organization's additional resources, blah, blah, blah. Yeah.
I consider the chaplains and health system the ambassadors to this new center.
Yeah. Yeah. Man, if I can butt in again one more time, actually, I see in the question and answer, some people are asking, what are the 2 spiritual screening questions that Deb's using that she borrowed from us? And I think those are probably from Stephen King's work on spiritual screening, right?
Right,
so
it is.
We'll put in the file with the video and the slides from this, we'll put in that reference so people can find those screening questions as well.
Great, thank you, George. Well, we're right at the end of our time. Are there any parting comments that either of you would like to give to our group today?
Thank you very much.
Thank you so much for this conversation and this opportunity. We look forward to continuing these conversations as we go through this wild adventure we have right now. So thank you for joining us, everyone, and have a great afternoon.
Bye.